Hello, everyone. Today's episode focuses on maternal health and is part of a multi episode series on this topic. Specifically, we will be talking about maternal health and preeclampsia, which is currently on the rise in the US and globally, responsible for over 70,000 maternal deaths and over 500,000 fetal deaths worldwide. This is a really important topic, and we will be speaking frankly about the mortality associated with preeclampsia, which can be a sensitive topic. This episode is not just for pediatric therapists, but for everyone who works in healthcare, anyone who loves someone who is pregnant or working to get pregnant, and for moms and moms to be who have experienced preeclampsia. All of us here at Pediatric Pioneers want to use this platform to make a difference in maternal health. Today, I'm excited to be joined by Patricia Corbin. She's an OTD, MS, OTR/L, and she's an expert in the area of maternal health and infant development. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social-emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy-to-implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Welcome, Patricia.
Thank you, Nicole, for having me.
We're so excited to have you here today. Could you get started by sharing a little bit more about yourself and how you became involved with maternal health and infant development?
Yes, thank you. I am an OT, like you mentioned, and I work in early intervention, but I have a long history of experience in preeclampsia. I actually had preeclampsia myself when I was pregnant, and it was 22 years ago. It was before Google, so I couldn't Google my symptoms. And I was told that the best thing I could do was to stay at home and be on bed rest and drink lots of water. And I learned quickly that that might not have been the best advice. I was considered a high risk patient, and no one gave me any information about preeclampsia. I was pregnant with triplets. I used IVF to get pregnant, and both of these things made me very high risk. It was my first pregnancy, and I also had an autoimmune disease. So I had four high risk factors for developing this condition. And no one told me a thing about it. So I didn't know what to expect. I didn't know that there was ways that I could modify my risk. I didn't know that I could be monitoring my signs at home. And I did not know how to recognize urgent warning signs that I was in trouble. So by the time I delivered, I was 34 weeks pregnant and I had an enlarged heart. I had something called cardiomyopathy. I had fluid in my lungs and I had kidney damage. And then I lost one of the babies. So when I came home from the hospital, I still had pregnancy induced hypertension. No one really gave me any information about how to keep monitoring those signs when I got home. I wasn't even told to take a baby aspirin, which we now know that that can reduce your chance of developing preeclampsia by 30%. And now we know that once you go home, your risk of dying is actually higher for the first 6 weeks after delivery. So you're at higher risk during that postpartum period. And about, in Georgia at least, 84% of the women who die from maternal mortality die during that postpartum period, up to 6 weeks.
Your story is really, I know it's very personal and it's really intense to hear this. One of the things I think that's probably important for our listeners is to explain what preeclampsia is.
Yeah, so preeclampsia is a condition that we develop either during or after pregnancy. And like I said, you are at risk for developing preeclampsia up to 6 weeks after you deliver. And so what happens is we have something going on with the placenta that causes our body to maybe attack it. They almost think of it like an autoimmune disease, but we
Mhm.
start developing an increasing blood pressure. So, for in my case, my blood pressure was very low when I first got pregnant. I was about 90 over 60, and it slowly started escalating. And with that escalation, you have a cascading events occurring. You start having a breakdown in protein in your kidneys because your kidneys are becoming damaged. Some
Mhm.
women go on to have increasing problems like liver damage. They can develop something called HELP syndrome. We can have blood clots. You can have a stroke. You can have seizures. And some women do die from having preeclampsia, and it's completely preventable. So there's no reason why any woman should die from preeclampsia.
I wanna thank you so much for sharing your story because I know it's a very personal story. And then, thinking about you being this pediatric occupational therapist, you were working in early intervention during this time, correct?
I started so about 10 years after I had my children, I started working in early intervention. So about 12 years
Mhm.
ago, I started working early intervention, and I started meeting more and more moms who were impacted by
Mm.
preeclampsia. And I was shocked at how little has changed since I delivered. There were so many women who still had no idea that they were at risk for developing preeclampsia. They had no idea that they even delivered early because of preeclampsia. I had one young woman who, this was 12 years ago. She was also considered a very high risk patient. She was African American, which made her very high risk. It was her first pregnancy. She had an autoimmune disease. She had a strong family history of people having pregnancy induced hypertension and even someone having preeclampsia in a prior pregnancy. And she also was on Medicaid. And all these things we know make you a little higher risk. So she had at least 5 risk factors. And when I met her, she had just delivered her baby. I get all the children who are transitioning home from the NICU. So most of the babies I see were delivered between 22 and 28 weeks. Her
Mhm.
baby was delivered around 23 weeks. And when I got to her home, I always ask the moms, tell me about your pregnancy, tell me about your birth history. And that's when everything just comes out. They tell me everything that happened, everything that went wrong. And she said they had to deliver the baby early because the baby was in trouble. As I'm listening to her tell her story, I looked back at her medical record, which I had in my hand, and I saw that she in fact delivered because she had preeclampsia and they were worried about her. Her blood pressure
Oh.
was well over 200, over about 160, 170. And she was not even aware that she had preeclampsia. So I said to her, they were worried about you. They delivered you early because they were worried about you. And that's what happens with preeclampsia. You have to be delivered early because the
Mhm.
mother is going to die if they let it continue. And she couldn't believe it. She said, "Are you sure, Patricia? Because my doctor didn't tell me that. My midwife didn't tell me that. The nurses never mentioned that to me. Are you sure this is true?" And I told her it was, and I gave her the information I had, and back then, I didn't know what I know now, but I told her what I did know. And when I left that day, went out the house, I thought, "Well, maybe I'm not the right person. Maybe because I'm not a nurse, I'm not the right person to give her this information." But I did tell her what I did know, and we had a great relationship. And a few years later, I got, another, referral for her, and this time she delivered 34 weeks. So I thought, "Oh, good, she must have done much better. The outcome is gonna be much better for this baby." Her first baby that I'd seen for many years ended up being diagnosed with autism, which we know now is, strongly associated with intrauterine exposure to preeclampsia. And so I get to the house and I knock on the door, and her little girl that I'd seen all those years earlier dragged a chair over to the door to open the door for me. And when I opened the door, I saw her lying on the sofa and she could not even lift up her head. And I said, "Oh my God, what happened?" And she said, "Patricia, I always heard that Black women die more frequently than white women in pregnancy, but I did not know I could get so sick." And she said, "I am on dialysis now and I need a kidney transplant." And I couldn't believe it. I could not believe how sick she was. Here she was in her mid 20s, a young mom with two little girls. And she really had to have this transplant or she wasn't going to make it. And unfortunately, Nicole, she did pass about 8 months later. She did not survive her preeclampsia that second time. So not only did she need this kidney transplant, she also was going into heart failure, and she did pass. And I felt very motherly toward her. She was in her early 20s. I was in my early 40s at the time, and she didn't have a mother in the area. And it affected me so deeply. And so when I found that out that day, I swore to myself, I will never let another woman die just because she doesn't have information. You do not have to be a nurse to give information. And,
Mhm.
as an OT, I am an educator, and I realize I have got to tell every woman I meet, and I'm in contact with women all the time in maternity age because that's what I do. I help their babies when they come home from the NICU, and they're all mostly still in maternity age when I see them. I educate every single woman I meet about her risk and how to modify her risk and how to monitor those signs and symptoms, but certainly how to be aware of those urgent warning signs that she's in trouble and she's got to get to the hospital because the
Mhm.
research says that preeclampsia, dying from preeclampsia is completely preventable. So we have to get this information out. And that's what I've been
Mhm.
doing for a lot of years is just talking to people about their risk and how to recognize those urgent warnings and warning signs and all those things that they can do to protect themselves from dying.
Yeah, that's a really interesting point that this is preventable. I think that might be a little surprising to people. Um, and, the power of education becomes quite important. And so, can you tell us a little bit about the risk factors for developing preeclampsia? Because I just heard you say that this is a preventable condition. And I think that that might be surprising to folks.
Yes. So there are several risk factors that we need to make women aware of. And the biggest one is being overweight or having a chronic condition like gestational diabetes or having type 1 diabetes before you're pregnant, having chronic hypertension before you're pregnant, having an autoimmune disease or kidney disease. If you're pregnant with multiples, you're at much higher risk. If you had a prior pregnancy, would you experience pregnancy induced hypertension, or if you delivered a small or premature baby? If you are under 20 years old, or if you're over 35 years old. In fact, women over 35 years old are at the highest risk of developing it and dying from preeclampsia. Also, if it's your first pregnancy, or interesting, if you've delivered within 2 years or greater than 10 years, it makes you much higher risk. But one of the biggest things I like to talk to people about is that Black women are 4 times more likely to die from preeclampsia than white women. And there's several reasons for that, but the biggest one is that they have a lack of access to care in a lot of regions. They have comorbid conditions like gestational diabetes and chronic hypertension and autoimmune disease. But one of the most interesting things is that there was a review of maternal mortality in the US, it was specifically in South Carolina. They found that discrimination was a contributing factor in up to 30% of causes of maternal mortality. So we clearly have a problem with systemic racism and implicit bias in the US healthcare system.
A lot of those stats that you just said to us were pretty interesting, some of the pregnancy 2 years or 10 years and just even some of the ages, like, under 20. I don't think that we would really be surprised hearing about some of the, disparities between Black women and white women, but I'm also curious about Latinas and, what are their stats like compared to Caucasian women?
Yes, that's a good question, Nicole. We do see that there is an increased risk for Latino women. And currently, a lot of the women that I see in my population in Southwest Georgia will tell me that they're afraid to go get help right now. They're afraid to go to the hospital to seek care. They may not have Medicaid or access to health care. So, we are seeing that they're kind of waiting a little bit too late out of that fear. And so the baby will have treatment once they're delivered, but they may not have any prenatal care.
Mhm. And that's, interesting to think about. But one of the things earlier I want to circle back to so we don't miss it is that you had said one of the factors was Medicaid. And so I know that you're saying that some women will have access to Medicaid and then some might not even have any health care, but that Medicaid in and of itself could be a risk. Could you explain that a little bit?
Yes. So every state has what's called a maternal mortality review committee. And we found, at least in Georgia, but it's comparable in almost every state, about 70% of the women that died of maternal related conditions will have Medicaid as a payer source. So we know that we can look at if we can look at that as a risk factor. We can see if the mom has Medicaid, we need to watch her more closely because she is at higher risk.
Mhm. Now, is that because of not that many physicians that were like OBGYNs have Medicaid access? Is that really kind of the issue there, or is it something else?
Some OB/GYNs don't take Medicaid, but I think the other problem is more socioeconomic and limited access. So we know that a lot of women, especially here in Georgia, live in regions that we call maternal health care deserts. So they
Mhm.
live in Georgia. We have over 150,000 women living more than 50 miles away from an OB provider or an OB hospital, and they're more likely to be on Medicaid. So they may not have transportation to get to that hospital. They may not be able to take off work every time they feel sick or they think they have a sign or symptom, or they may not have childcare for their other children to get there. So there's a lot of other risk factors involved in that. But typically, when we have a mom who has Medicaid, she also is going to have other socioeconomic causes that might contribute to maternal mortality.
And we've been talking here about occupational therapy's role with working with moms with preeclampsia, talking about maternal health, talking about even infant development as well, which we'll get into a little bit more. But I'm now seeing so much opportunity, especially if we go into the home, because we might be the only healthcare provider interacting with these moms at that scale where we have time to talk to them, time to educate them and hear their story.
Okay, that was a great comment that we need to talk about, Nicole, because a lot of women feel like they're not being listened to, they're not being heard. And in fact, that was what actually stimulated me to start this whole project. I had two moms on the same day retell a story to me that was so similar. Like I said, I always ask the moms, tell me about your pregnancy and your birth history. And on the exact same day, two different women told me, Patricia, I presented to the hospital 3 times on the day I delivered. And the first 2 times, I was told, look, you're over 35, you're overweight. This isn't going to be an easy pregnancy. You're going to have to toughen up, is pretty much what they were told. And they both told me that on the third presentation to the hospital, one mom had developed HELP syndrome and nearly died, and the other mom had a seizure because her preeclampsia had progressed to eclampsia, and she obviously had to have an emergency C-section. And both of these women retold their story crying, and they said nobody would listen. I kept telling them, I don't feel well. Something's wrong. I have nausea. I have vomiting. I'm having a headache, or my vision looks different. And the problem was they failed to recognize that their blood pressure was slowly escalating. And so both of these women had started their pregnancies with low blood pressure that was, 90 over 60 or 70, but it slowly was increasing. And a lot of times at the hospital, they don't consider it really high blood pressure until it's over 160 over 90, but it was high for these women. Both of them had blood pressure that was increasing to like 135 or 140 over about 80 or 90. And regardless of it not being appreciated in the ER as being really high, it was high for them. And they both said, I kept trying to tell them my blood pressure is high for me, something's wrong. And they both said nobody would listen.
Mm.
And, so when I heard those stories, I came home that day and I thought, I'm so sick of hearing that no one would listen to these women. And that after all these years, 20 years after I delivered my babies and I didn't have the information, and 10 years after the mom that I was so close to passed away, that the information is still not making it to these women.
Mm.
Somehow the information is not getting to them. They're not aware of how they're in danger and how to recognize those urgent warning signs, and that there could have been some things they could do to modify those risks. So I came home from work that night and stayed up very late thinking, what can I do? There's got to be something I can do to make a difference. And that's how I came up with this project that I called the Preeclampsia Project. And went to the health department where I worked, and I said, "Hey, I have this great idea. Why don't we start partnering with every person who comes in contact with a woman of maternity age, and we give her this information?" I had already been doing this for 10 years just with the women on my caseload, one to one, but I thought we need to make a bigger impact. And the way we could do that is partner with all these different programs. In Georgia, we have something called Georgia Strong. We have in-home visitors. We have WIC. So there's so many places and opportunities that we're missing as practitioners, we're missing as stakeholders to educate these women about their risk. And like I said, this condition is we should not be dying from it. It should be prevented from progressing that far. So if they have the information they need and the tools they need, so they can monitor their signs and recognize those urgent warning signs, then we can save lives.
So I love, Patricia, how you're talking about thinking outside the box and really thinking about the stakeholders involved and partnering with them. Um, I want to also help the listeners understand how preeclampsia affects the health of the mom and also the baby. We talked a little bit about the risk factors, but before we get more into your project, I'd love to hear a little bit more about how it affects the health of the mom, how it affects the health of the baby, because we also are talking about infant development here as well.
This is an area that just is not discussed enough. There are long-term complications and impacts of preeclampsia on both the mother and the baby. We hear a lot about what happens to the mother, but not quite enough about the baby. I wanted to add too that I had read a recent study from the American Journal of Obstetrics and Gynecology. They reported that the U.S. healthcare costs for treating preeclampsia in women and children were over $2 billion just in that first 12 months after delivery. So it's about 1 billion for the mom, and then 1.18 billion just for treating that baby for the first 12 months after delivery. So it really impacts our healthcare, and this is an area of great need where I think occupational therapists could make a huge impact. So after a woman has preeclampsia, her risk for developing heart disease and stroke is more than doubled. And they also have a 4 times higher risk for high blood pressure. And this is something really important for us to share with their moms because, as I mentioned, no one told me anything about that. I had no idea that I was at increased risk for developing those conditions. And apparently, it impacts us for 10 to 15 years after we delivered. And there is some research also that says that 2 out of 3 women will die from cardiovascular disease after having preeclampsia. So it hugely impacts women's health. We know that between 50 and 70,000 women die worldwide from preeclampsia every year, and there are over 500,000 fetal and infant deaths. So also, when you think about preeclampsia, the way to protect the woman's life is they have to deliver that baby prematurely. So you can expect all the complications that go along with premature delivery. We see these babies born early. On my caseload, between 22 and 28 weeks, so early and so small. So of course, they're more likely to be diagnosed with CP. All of the babies on my caseload have feeding difficulties, and that's something that we'll see for many, many years. A lot of clinic owners who are listening will see that they have a child who has a feeding difficulty. They really need to ask about their pregnancy, the mom's pregnancy and her delivery, to see if maybe they did have preeclampsia. They're also very small for gestational age. So if you think about anything that's going to impact the mother's blood flow and oxygen, like having hypertension, during pregnancy, it's also going to impact her placenta. So, if we have a poorly supported placenta, then we know that that's going to decrease blood flow and oxygen to the baby too. So, the research indicates that babies with intrauterine exposure preeclampsia have an increased risk for developing a neurodevelopmental disorder. It's around 35 to 50%. But Nicole, I can tell you that on my caseload, of kids who are delivered between 22 and 28 weeks to women who had preeclampsia, almost every single one of them will be diagnosed with autism.
And you know this because you have a private clinic that you own, and you treat
Yes,
exclusively early intervention babies, correct?
yes,
And children, right?
right. Right. I personally see babies that are from birth to about 2 or 3, and then we decided to cut off our caseload at 5 years at the
Mhm,
most because we have so many kids that are being delivered earlier and earlier and surviving with more comorbid conditions that we've got to see quicker. Because, as I mentioned before, they all have feeding issues. So we need to keep room on our caseload for these kids who need speech for speech and for feeding, and have all these issues with emotional regulation.
mhm,
They really are. They come out early. They're dysregulate when they're born, and it takes many years for them to learn to regulate and to
mhm,
help parents co-regulate with them.
mhm,
And there's also a strong association between preeclampsia and congenital heart disease. And interestingly, I had mentioned before my experience with preeclampsia. I have a son who has autism, and he was the smaller of the 2 babies that survived. He was always the one with intrauterine growth restriction, and he I knew around 4 to 6 months, age adjusted, that he was going to have autism. And then my daughter has a congenital heart defect. She has something called pulmonary stenosis. So it was many, many years before I realized it was related to me having preeclampsia.
mhm.
And I see it so much in my own practice with these babies coming home. These are 2 things that I see all the time with those little kiddos.
Mhm. Wow. Yeah, I mean, I think this might be kind of surprising information to a lot of therapists, but I think some are probably saying, "Yeah, I see this too." And maybe it's slow to be recognized in the statistics that are out there. So we're talking here, and earlier I did an introduction where I said that this episode is really helpful for anyone who works in pediatric healthcare or even anyone in OT that maybe works in acute care, because you might see some of these women in an acute care setting or other situations, and just anyone who's of maternal age, whether it's a friend or you're seeing them in the clinic. Um, so we're talking about occupational therapy, but I kind of think it's broader than that. But going back in and narrowing it back into to occupational therapy providers. Why do you think it's important to discuss the role of the OT practitioner in maternal health? Because this is an emerging area that we're looking at.
It is so important because we have we are just really well suited for maternal health. We have that really holistic approach to the mother's well being and her ability to participate in her meaningful occupations. As OT practitioners, we tend to focus on health and wellness rather than treating an illness like preeclampsia after it occurs. And that's something we usually see with that traditional medical model where they wait till the woman is experiencing a poor outcome, and then her preeclampsia is treated.
Mm,
Whereas OT practitioners, we want to focus on making sure she has a healthy lifestyle, making sure she can change her habits and make new routines to make her healthier, not just during her pregnancy, but for long term.
mhm,
The other thing that we see in women's health is that after delivery, the focus is really on the mother's role of caring for the baby. So, she forgets about herself. A lot of the practitioners forget that mom just had a baby. And with these women who have preeclampsia, most of them will have an emergency C section. So they come home from the hospital after having a major surgery, but nobody is really tending to mom, including herself. So, I mentioned earlier that it's more likely for them to die after that delivery.
mhm,
So I think they go home with this false sense of security that they think, oh, I just had the baby, I'm safe, I can get home. When in fact they're at a much greater risk of dying once they get home. I can't remember if I mentioned this already or not, but in Georgia, 84% of the women die after they deliver,
mm,
and and that's pretty consistent across the US. It's around 80% die during that postpartum period for various causes. But again, preeclampsia is a preventable disease.
mm. So
So,
80% of the deaths happen after birth, which I think is a little surprising. It is for me anyway. But
yes,
I can imagine, just from my own experiences and talking to people like you who are working in these emerging areas, that you might get a little pushback on
I do.
occupational therapy in this arena. So how are you advocating for these opportunities and explaining to other healthcare providers that this is within our scope of practice?
I do get a lot of pushback, Nicole. In fact, I had been working for the health department for 12 or 13 years when I came to them with this idea of partnering with everybody in the community. And they all said, "We love this idea. This is wonderful. But we think it seems like a nursing initiative." And so I really had to advocate for the role of OT in women's health and maternal health. And they knew me already as a person who's working with these premature infants, but they often would say, she's an OT who works just in rehab. And so I really had to advocate about how we are certainly qualified to work in this area. We really need to promote ourselves as the experts in health and wellness because we are. We are so good at helping with medication management. And when you think about health maintenance is an occupation. But I think the most impactful thing I'm doing is collaborating with these women to help change those habits and routines. I'm trying to help them see, just looking at their daily routine, how they can embed their blood pressure monitoring in the morning and bedtime, just as part of their daily routine that they're already doing. I
Mhm.
also have them take their blood pressure every day and then keep a journal of their rates so they can share that with their healthcare provider. I'm trying to help them develop lifelong healthy habits rather than just during their pregnancy because they are at risk for many years for chronic hypertension and stroke after they have a baby because of preeclampsia. The other thing I'm doing is educating them on their risk factors and how to modify the risk factors using things like their diet. The College of OBGYNs really strongly recommends that all pregnant women are on a Mediterranean diet or DASH diet. They need to drink more water instead of soft drinks. We really need to help women know how important it is to move their body every day for at least 20 or 30 minutes. They need to talk to their physicians about losing weight to reduce the risk from obesity and stopping smoking. Also, I mentioned medication management. A lot of women don't know that taking an aspirin can help reduce your risk of developing preeclampsia. That was something I wasn't told. I wasn't prescribed a baby aspirin. So I always tell women ask your doctor if you should be taking a baby aspirin. The research that I read recently said that there is a 30% reduction of developing preeclampsia just by taking a baby aspirin. So that's something they really need to be talking to their provider about because most of the women on my caseload were not told that they should have been taking a baby
And that's
aspirin.
something important as in the early parts of their pregnancy to talk to their physician about. So, tell us a little bit more about what the recent research says on this topic.
About
Preeclampsia and just general research information, because I think that's important as we're thinking about being evidence-based practitioners, but also just kind of I know you've told some of the stats already, but just kind of understanding the impact of preeclampsia so that we really
okay.
understand it from that level. Mhm.
Okay, so some of the stats I really like to talk about are about how it's impacting Black women at a much higher rate than any other race combined. So we know that they are between 4 and 5 times more likely to die than a white woman and to develop preeclampsia in general. So that's something really important that we need to recognize and take seriously, and that will really help guide our intervention and how to partner in the community. One of the other things that is really important for, especially pediatric providers is to know that there is a 35 to 50% increased risk for children to develop a neurodevelopmental condition.
Mhm.
And it goes back to that anything impacting the placenta is going to impact the baby. These babies are more likely to have what's called intrauterine growth restriction. You might hear that as IUGR. That means they were very small for gestational
Mhm.
age. So something caused them to be very small, and we know now it's because that placenta just was poorly supported. And again, we talked about earlier about how if the mother's blood flow is restricted, if her oxygen is restricted, the placenta is also going to be poorly supported, and then the baby's ability to get that blood flow and oxygen is going to be restricted. We also need to talk about how preeclampsia does not only affect the mom, but how it affects the baby and how many kids are developing other comorbid conditions because of that. And thinking about the impact of all these kids being born so early. You know, up to 22 weeks gestation, these babies are surviving.
Mhm.
And they're surviving with a multiple of comorbid conditions And that's something that we really need to get in the habit of asking our families when we get in the pediatric clinic, when we if you work in the school system. A lot of my colleagues who work in the schools tell me that they're now asking the moms of children who are diagnosed with autism or who are about to be diagnosed with autism. They're now asking the moms, "Hey, can you tell me about your pregnancy?" And they are so shocked about how many will tell them they either had pregnancy-induced hypertension or they did develop preeclampsia or eclampsia or even HELLP syndrome.
Mhm.
So we really just need to get in the habit of having that conversation.
Mhm. And I'm thinking contextually here too. My clinical reasoning is kicking in, and I'm thinking if you have a child with autism or any other neurodevelopmental condition diagnosis, you're going to be spending a lot of time there. We already know the research says there's more time devoted to raising a child diagnosed with autism. There's more money devoted to it, so it puts you at further risk of poverty, but also just from a time allowance, we know that the mom is gonna focus on the kid. So it becomes to me, I'm almost thinking like it's gonna be even easier for them to not pay attention to their own health because they are focused now on a child with autism that takes a lot more resources of time, effort, energy, attention, money, etc.
Yes. And if you're already in that pediatric practice and you know this, you do need to talk to that mom. I always say if you have any role that places you in contact with women of maternity age, you really have a responsibility to educate her about her risk factors because once she's had one baby early, she is much greater risk for having the next one. So we can talk to them about planning their next pregnancy. At the health department, you can get free birth control because we know that if they get pregnant again within the first 2 years of delivering the baby with preeclampsia, they have a much greater risk of developing preeclampsia again, and it's going to probably be more severe.
Mm,
So, talking to women about those risks while you have them there is crucial. It's also a great time to talk to parents about preparing to meet their baby's needs and how to
mm,
facilitate their development because they're in the clinic. One of the things that I see most frequently with these babies coming from NICU is that they enter the world too early. They have physiological and emotional dysregulation. These babies can't even regulate their blood pressure and their heart rate and
mhm,
their body temperature.
mhm,
And we're trying to expect them to be able to eat when they can't even, they're born before the suck, swallow,
mhm,
breathe reflex has even been integrated. And we're expecting them to be able to breathe while they're swallowing
mhm.
and to remain emotionally regulated when they can't even control their blood pressure and heart rate.
Yeah.
So teaching the parents about how to recognize that these kids are dysregulated, and here's a way that you can co-regulate with them.
Mhm,
We really need to help them prioritize that emotional regulation before we do anything else, because once they're in that dysregulated state, they're in fight or flight. Those higher cortical functions shut down, and that's when we're going to see behavior issues. That's when we're going to see feeding issues. Those feeding issues continue for many, many years. We'll see kids who are very picky eaters, who have a very restricted diet, and, when I look at those children who are 3 and 4 years old who have that restricted diet and I ask about their, birth history and mom's pregnancy, I very frequently find out that she did have preeclampsia, and I can look at videos of early feeding, and I see where they were very discoordinated. They could not organize that suck, swallow, breathe, and mom will often say, "Yeah, he never could latch to the breast." So
mhm,
finding out that we had a history of difficulty with breastfeeding, or we had a difficulty latching even to any nipple is really common. They don't recognize that their child letting milk spill out of their mouth or turning their head away and finger splaying, those were all cues that
mhm.
they were and that's something that we can really help parents is recognizing those feeding cues that the baby's in trouble and we need to give them more support and time.
Yeah, so I'm hearing all these opportunities that we can take into practice, right? The first thing is obviously this is a pediatric podcast, so we're thinking about the pediatric angle, and now we're thinking about all these opportunities to work on the co-regulation, co-occupations, feeding, um, all so much that's going on with the baby, and also I like how you were talking about going back and making sure that we're always asking about the birth history and understanding if the mom had preeclampsia, because now we have those other opportunities of educating the mom, and thinking about lifestyle redesign, which is something that we are experts in. And I know we had talked about that there's a systematic review from 2017 that shows that when you do self monitoring, it's effective only really when you do it in conjunction with the medication management, patient education, lifestyle redesign, and counseling. So we know that the approach that you're using is evidence based, right? And I know you said
Correct.
earlier that you have this kit that you created that you use with the moms. Would you like to share a little bit about the kit and show us what's in that kit so that folks could actually replicate it?
Yes. So when I started talking to the moms about the importance of monitoring their signs and symptoms, I decided if I could come up with enough money to make these kits so we could give them everything they needed, the tools they needed to really monitor the signs so we can empower them to take their health in their own hands. I came up with a few ideas of ways that we could make that easier for her. So, one of them was a blood pressure monitor, and you can get this at Walmart. This one is from CVS. You can get them from anywhere. They're all available over the
And you're
counter.
just showing, like, the automatic blood pressure cuffs that you can get anywhere off the shelf? Okay.
Yes. And then I provide urine testing strips. And the reason why I think it's really important for women to have access to urine testing strips is because that's one more measure that they can record that shows them whether or not they have protein in the urine. Once the kidneys are damaged from this chronic hypertensive state, the kidneys are going to start breaking down protein. So the women can they can just pee on the urine stick and it immediately shows up if they have protein and how much.
Oh.
So if you think about our moms who live in these healthcare deserts, like for my moms, some of them literally live an hour and a half away from an OB provider, an OB hospital. And it's very easy for them to say, I'm just going to lay down and I'll feel better in an hour or two. And that's why they're at such risk for dying. They stay home, they ignore themselves, they're worried about the baby, who's going to take care of the kids. They may not have the transportation to get them to the hospital, and they know it's an hour and a half drive there and an hour back. They may not have 3 hours to donate to their own health care.
Mhm.
So I help them see how important it is to monitor that blood pressure. If your blood pressure is escalating and you have these other signs and symptoms like swollen legs, you've got a headache, you're seeing spots or having vision changes, you're having nausea and vomiting when you haven't had that since your early pregnancy. And you also know from the urine testing strip that you have protein in your urine now. She knows these are urgent warning signs. I've got to get help immediately.
Mhm.
Sometimes, like for example, when I first called my provider and said, I think something's wrong, I don't feel my baby's moving. They first tried to tell me, "I think it's okay, you're very small and you have 3 babies in you." But I insisted on going. So if the woman is pregnant and her baby isn't moving as much, she knows, "Okay, these are ways that I can protect myself and protect my baby." So all these little things in the kit, as you mentioned, you can get them anywhere. You can get them at Walmart, you can get them at any pharmacy. But it's important for her to have access to these things. I have read legislation in a lot of states now where they're trying to make a bill where women will be given, every pregnant woman will be given a blood pressure monitoring
Okay.
device to have home.
Uh-huh.
So I'm hoping that changes like that will happen. So we have one more way to protect women and empower her to take control of her own health and take control of her blood pressure because that's the most important thing she can do is get that blood pressure under control and then working very closely with her provider about what she needs to do to get her blood pressure under
So you've
control.
got the blood pressure cuff in there, you've got the urine strips. Is there anything else that you have in the kit?
Yeah, I put these compression stockings because sometimes they'll have swelling and it might not mean that they're in preeclampsia unless they have all those other symptoms. But I do encourage them to use their compression stockings. And then I put little pamphlets about preeclampsia, everything they need to know. I have them in English and Spanish. So it
Mhm.
has everything they need to know about their risk factors and how to modify those risks through healthy lifestyle choices like the diet and drinking water and exercising and stop smoking, and especially how to recognize those urgent warning signs. So
Mhm.
everything is in the kit that they need to protect themselves from dying from preeclampsia.
And is there somewhere where we could get these, brochures or pamphlets to have for, the moms that are in and their families that are in the clinic?
There is. So, my brochures were made specifically for Georgia, but most of the information I got, I was able to get from the CDC.
Okay.
They started a campaign called Hear Her, HEAR. And this Hear Her campaign was started because so many women say nobody will listen. Just like the women that I had talked to that said they tried to tell them that something was wrong, but nobody would listen.
Mhm.
So you can go to the CDC website to the Hear Her campaign, and they have all their materials for free and you can print anything off. They even have posters that you can hang in your clinic, but they have brochures that you can hand out. So all this information is available free. And also, therapists can go there, practitioners can go there and educate themselves if they want to learn more about pregnancy related conditions and other causes of maternal mortality. One thing we didn't mention was that up to 20% of maternal mortality is caused by mental health and drug use. So there's so much information available on that CDC website that I would really encourage anybody to go to
We
and
just
look at.
talked to Teddy Buckner about that on the podcast on another episode where she's talking about maternal mental health. So this is part of the series. So folks can go back and listen to that and hear a little bit more about that because that's an important statistic as well, for
It
sure.
really is.
Yeah.
That is fantastic. And I'm glad you brought that up because each state has their own maternal mortality review committee. Florida has their own, for example, that you can go to and you can look up your state rates and county rates of maternal mortality causes online. For example, in my state of Georgia, we have about 32 women dying for every 100,000 births. But in the area where I live in Southwest Georgia, it's a very poor area. We have some of the lowest access to care here in this region. We have 67 women dying for every 100,000 births. And I mentioned to you that earlier that 4 times Black women will die in Georgia than white women. So we know there's something that we need to do. I always say when I talk about this at conferences that this really is a call to action for
Mhm.
OTs to do something to make a difference.
Yeah, and I think I wanna reiterate something that you said earlier with this call to action, right? That this is where we can really lean into our expertise, right? We are
Yes.
experts in health and wellness. We are experts in building routines and embedding different things into the routine to build it and then that lifestyle redesign piece. We are experts in educating our clients and patients. And one of the things I want to have you share with us, a couple things that I want to circle back to. The first one is what are the numbers that we are teaching them to monitor? First of all, what are the numbers for preeclampsia? What qualifies you as having preeclampsia?
So the numbers we want to look at, and you can find this on the American Heart
Mhm,
Association. They have a really nice color chart that will tell you what is considered hypertension.
mhm,
It used to be that people thought, oh, if I'm around 120 over 80 to like 130 over 90, then I'm good. I have normal blood pressure. We now know that is the first step. That's the first stage in developing hypertension. We really need our blood pressure to be below 120 over 80. So there's a lot of women walking around with early stages of hypertension. What they typically look at in the hospital is a blood pressure reading of 160 over 90 and above. But here's what's important to know about preeclampsia. It's not just that you have high blood pressure. It's that escalation of the blood pressure. So, as I mentioned in my example and in the women that I've met that inspired me to do this project, they started out with very low blood pressure. Their blood pressure was 90 over 60 and they had all these other signs and symptoms. So they, just like I did, I was very swollen. I developed carpal tunnel because my hands were so swollen. And the other mothers had other things like, they were in vision changes. I also had blurred vision, and I had no idea that this was another sign that I was in trouble.
Mhm.
So they need to be looking at all those things collectively, not just for that reading of 160 over 90, because that fails to predict how many other women might
Mhm.
develop it. It really is that escalation that we need to look at.
So
So if they're
that's really
telling
that
you,
journal that you were talking about. If you have it and you're monitoring it, then you're gonna see that escalation.
that's right, and then they can take it to their provider and say, "Look, my blood pressure was 90 over 60, and now I'm at 130 over 90 or 130 over 80, and it's slowly increasing."
Mhm.
And so, if it's increasing and you have these other signs and symptoms, and you know that you have protein in your urine, you are in trouble. You've got to get help.
Mhm.
And so those are those urgent warning signs that we really need to make sure they're all aware of. And you never know. Just from me talking to you today, you may have a friend who mentions to you or a student who says, "Oh my gosh, my legs are so swollen," and she's 25 weeks pregnant. And then when you say, I just heard about this condition called preeclampsia, and you notice she has these risk factors. It's so important to be able to share that. Frequently, after presenting at a conference, I'll have women come up to me and say, I didn't know that I had preeclampsia, and it sounds like I did. No one told me I delivered early because I thought my baby was in trouble. Or at AOTA, and several women say, I think this happened to my sister or to my friend. And now they're able to share this information with other women. So that's my hope is that as more people hear what the risk factors are and more people hear what those urgent warning signs are, they're able to share that with them. But then, of course, as practitioners, as you mentioned, we really are the experts at health and wellness. It's really our responsibility to talk to them about how to modify those risk factors.
Mhm.
There's so many things they can be doing to reduce their risk
Mhm.
and to not only be healthier during their pregnancy, but for the rest of their lives. If they could develop these new habits and routines, they'll be healthier for the rest of their lives.
Right. And that occupational lens that we bring to this about their role as a mother and the co-occupation piece and the lifestyle redesign is just so important. I'm one thing I also want to go back to. You said something about being diagnosed with something called the health
Yes.
condition. Could you explain what that is? And I think it's HELLP, correct?
Right.
Okay.
Right. So and a lot of people don't realize when they delivered because of HELP syndrome, they actually had preeclampsia first, and it was able to progress to HELP.
Okay.
So so the stages are preeclampsia. We know that the blood pressure is elevating. You have all these other symptoms coming along with like vision changes and swelling, nausea, vomiting, and then as that progresses, we start having organ damage.
Mm.
Like in my case, my heart was becoming enlarged and my kidneys were starting to break down. Once you develop eclampsia, you're having seizures, you're having these neurological changes. Some women will end up having strokes. We can have blood clots, hemorrhage as a result of it. But then syndrome happens when it has progressed so far, the liver is now damaged. So what we see is what's called hemolysis of elevated liver enzymes. That's the HE and low platelets.
Mm.
And so this condition is very deadly. And once that occurs, of course, the baby has to be delivered immediately. And the woman usually will have a poor outcome. And of course, the baby may have a poor outcome as well.
Yeah, so that's like another one that's really important to know about. So we've been talking about, the numbers and then bringing that into practice. And so to wrap this up, because it's been a lot of really important information, what would be your top 3 actionable takeaways for practitioners and just other folks listening today to take this information and put it into practice?
I'm so glad you asked that because the things I always want practitioners to know is that if you have a role that you are in contact with a woman of maternity age, you really do have a responsibility to educate her. We all want to think, oh, somebody else is doing that. That's the nurse should be doing that.
Mm.
The physician should be doing that. But really, if you have that role and you are with that woman, if you're already treating that mother baby dyad, tell her about her risk factors. You really may be the only person to do that. The other thing is, I really want them to know how important it is to ask the parent about the birth history and the pregnancy. When they come into the clinic and they see they have these feeding issues, they see that I think they're showing markers for autism or neurodevelopmental disorder. Ask them about that early pregnancy history and her delivery, because you might get some clues that's going to help you and help you prepare them for the future. That's the best way to prioritize that emotional regulation piece, because if we have a dysregulate baby, the baby is not going to be able to focus on feeding. It's not going to be able to focus on speech. My little boy did not start talking to us 3 because he had autism. But once we got him really regulated, the speech came and it got so much easier. And the other important piece is you can continue to educate yourself on preeclampsia and eclampsia and HELP syndrome by going to that Hear Her campaign. And
Mhm.
like I said before, all that information is available free to you. You can just download it from the internet. You can have pamphlets available. So there's lots of ways to continue to educate yourself and to collaborate with other people in the community.
Mhm.
So it's a great way for us to continue to promote ourselves as OTs and establish partnerships in the community to help make a difference in maternal mortality.
Mhm. And then if I know you were saying one of the things was to ask about that birth history. So we wanna really specifically ask about preeclampsia, pregnancy-induced hypertension, HELP syndrome, and really make sure that we have that information. If I'm talking, I think this is probably another important takeaway. If I'm talking to a mom and I'm getting this birth history and the kid's 3 and she tells me she had preeclampsia, what's the takeaway there?
So that is a great time to talk to them about all those risk factors and all those long-term complications that are involved with having preeclampsia,
Mhm.
because they probably don't know. In the data that I've collected with women who have preeclampsia, I found out that almost none of them knew that they had these long-term complication risks. So
Mhm.
they didn't know that that meant that they were more likely to develop chronic hypertension. They didn't know that they were more likely to have a stroke, and they didn't know that 2 out of 3 women will die of cardiovascular disease after having preeclampsia. So I think that's a great way to extend your conversation with the mother once she tells you, "Oh, I had this pregnancy
Mhm.
and I had preeclampsia." This is a great time for you to lead into that next conversation about her risk factors and how to protect herself.
Yeah, and how do you go about that conversation? Because this is a lot to lay on a mom who's come to therapy to have her child looked at and get help for her child. And then all of a sudden, you're kind of giving them this, hey, you have 10 to 15 years after your preeclampsia diagnosis that you have to be concerned about your health.
So, I actually just make that a natural continuation of my conversation I'm having with them. And as I've gotten more seasoned as an OT, I realized that OTs are really comfortable talking about blood pressure. For example, if the patient had a spinal cord injury,
Mhm.
we make that a very typical part of our treatment plan. And so, I think as providers become more comfortable talking about it and accepting that they really are the expert at health and wellness, I think that conversation is gonna get a whole lot easier for them.
Mhm. Yeah, I agree. We already do it. I think we just don't maybe think of the mom as our client. Right, but the
Yes.
whole family is our client. Everybody's involved, and when they have we have this opportunity to be the ones to really help them understand their health, I think that's like you said, it's imperative that we jump in and do that. So, thank you so much for the information and also the direction to go to the Hear Her campaign, the website, because I think that's helpful, and you said that was in the CDC's website, correct?
That's right.
Okay.
Yep, they can go right to the CDC website and, click on Hear Her.
Okay, great. Well, to wrap things up, and I mean, I probably could talk to you about this forever because I think it's just so important. I think the stories are devastating. I mean, I don't know any other word to say. These stories are so important to understand, but I also see so much opportunity, and I feel optimistic that if we really take this call to action, we could make a difference. So, on that note, to wrap things up, do you have any final words of wisdom or inspiration that you would like to leave with the audience about this call to action?
I think the most powerful thing is to remember that it's all of our responsibility, that when you are with her, if you have any woman maternity age, just take that responsibility to educate her because you really might be the only person that gives her that information. And there's no reason to let another woman die just because she doesn't have education.
Mhm. So talk to your friends, talk to your family, talk to your clients, talk to your other healthcare colleagues because this is really important. So, on that note, that's all the time that we have for today. I want to thank again Patricia Corbin for the insight, the practical takeaways on this really important topic of maternal and infant development. Thank you, Patricia.
Thank you for having me.
Thank you for tuning into this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com.